Okay, chapter 25, the high-risk newborn. High-risk neonates is a newborn regardless of their gestational age or their weight, who has a greater than average chance of morbidity and mortality due to either the conditions or circumstances associated with their birth or the adjustment period after they're born. So birth weight and gestational age is one area where we have some issues. Birth trauma, maternal substance use, infection, and congenital anomalies. Birth injuries sustained during labor and birth are a lot of times avoidable, but some of the times they do happen. So we really want to pay attention to those. That would be your shoulder dystocia babies, your vacuum babies, any unusual circumstances, your C-section babies. You want to look for skeletal issues. With the shoulder dystocia babies, they'll get sometimes what's called an Erb's palsy, where they get paralysis in the arm due to the stretching or the ripping of that neural Erb's chain of neurons in their neck. Facial paralysis, phrenic nerve paralysis, and neurological injuries in the brain, so brain bleeds and things that can cause permanent brain damage. And that's from anoxia and sometimes traumatic injuries. So Erb's palsy, this is showing you that group of nerves in the shoulder, and when that's stretched, because we're trying to get that shoulder under the pubic bone in a shoulder dystocia, that can cause the baby's arm to be have some paralysis. And this is showing you a picture. That arm is just kind of hanging out low, and a lot of times their wrist is flexed backwards, where this arm is moving and happy and everything like that. Some of these, when they're just stretched, can resolve with physical therapy and time. Some of them are permanent. This is showing you a baby with facial paralysis. Again, sometimes that can go away and resolve, and sometimes that is permanent depending on the cause. So just definitely going to have a close contact with a pediatrician and while we're figuring out what happened. Neurological disorders, there's a table 25.2 that kind of summarizes them. These things are caused by brain injuries and anoxia. So you have your hypoxic ischemic brain injury, your germinal matrix or intravascular hemorrhage, and your intracranial hemorrhages. And basically we find these things out, we look for things like apnea, seizures, muscle weakness, twitching. Again, those are all in that table. I have a couple pictures of, or a couple videos of infant seizures, because I think you guys, unless you see these videos, have no idea what an infant seizure looks like. Sometimes it's twitching, sometimes it's a repetitive movement. They're very subtle. Sometimes it's just in the eyes. So really, neonatal nurses have to really know what these look like and be aware of really examining the baby and looking for those. Infection is also an issue, especially if mom had GBS, influenza, E. coli. Those things are congenital infections. Those other infections that happen later, are the 7 to 30 days, can also happen. Again, E. coli, influenza, COVID, things out there in the world. Staph is something that we see later as well. We're out looking for fever. We're looking for signs and symptoms of them. Again, those are in table 25.4, apnea, sleepiness, etc. And then we want to get some blood studies on them and of course treat them with antibiotics if this is something that has occurred. This is where we really talk about our torch infections too. So did mom have any of these while she was pregnant? Toxoplasmosis, hepatitis B, HIV, parvovirus, West Nile, Zika, rubella, cytomegalovirus, and herpes. So if mom had any of those, we're really doing some extra assessments and looking for any signs and symptoms that was given to the baby. And here are some of them. Here's a baby with cytomegalovirus. These are actually syphilis lesions on the baby, and then these are herpes lesions on the baby that they all got from their mother. HIV can be passed to the baby too, so sometimes we choose to do C-sections to decrease the transmission of HIV on the mom. We really don't let moms deliver vaginally if they have active herpes lesions, but maybe there's a lesion we didn't see, so then it's passed to the baby, etc. Drug-exposed infants is super common, unfortunately, now. This is anything from tobacco, antidepressants, alcohol, marijuana, etc. Tobacco usually causes low birth weight and some congenital defects. We really try to have women not smoke when they're pregnant. Alcohol causes fetal alcohol syndrome and some other neurocognitive developed disorders. Marijuana can cause preterm stillbirth, IUGR, and some mental health issues in the child's later in life. Opioids is why we have the neonatal abstinence syndrome, where we're giving morphine for. And it's important, if mom was on opioids when she was pregnant, that we don't use Narcan when resuscitating a mom, because that can cause them to stop breathing, etc. Cocaine can cause an abruption. We've talked about that. Preterm birth, death. Again, neonatal abstinence syndrome, mental health issues in that baby, thinking problems, math language deficits, learning disabilities. So all of these drugs can have some very long-lasting effects. Meth is the same as cocaine. SSRIs can cause some hypertonia, some wakefulness, high-pitched crying, and feeding problems. Again, risk versus benefit of mom being on an SSRI, like we talked about, especially later in pregnancy, if they've had a history of depression, it's more risky of her not taking care of her mental health and then that affecting bonding and her being able to care for herself and her baby than it is to have this syndrome in the baby. So we really have to weigh the risk and benefits with the woman. And then benzodiazepines, these are your anxiety meds, your Xanax, your Ativan. They can have some very similar NAS symptoms of opioids and can last for quite some time. And sometimes they don't even start showing till day 730 postpartum. And so they're already home, and now they're having these abstinence syndromes, crying, inconsolable, etc. So neonatal abstinence syndrome, there's a box, 25.2, you really need to look that over. And some of those drugs, like I mentioned before, they may not have symptoms till a week or so after they're born. Again, they're already home, and now these symptoms are happening. And a lot of these babies are irritable. They won't stop crying. They're inconsolable. And then parents who already have drug problems have this kind of baby, then a lot of the times those babies get shaken. They also can be failure to thrive babies because they're not eating and they're losing weight. There's a scoring system that you'll see in Muskegon be used on those babies. It's called the Finnegan NAS scoring system, and that's where we kind of grade how that baby's doing and make some decisions on how much medicine to give them. And again, problems with eating and sleeping and consoling. So there's a model that says we can go ahead and give them that morphine drip. There is some body of literature that says that maybe having someone consistently rocking and skin to skin and consoling that baby is just as good. This is sometimes hard to do. There are some nurseries around the country that take volunteers, and that's what they do all day long. They rock and cuddle and hold these babies that are coming off of substances. This is one place, neonatal abstinence syndrome, where we will put that baby prone. We really try to teach parents to never put them on their stomach, that those babies are always sleeping on their back. So if we have a baby with neonatal abstinence syndrome and we're proning that baby because it provides more comfort, babies are more comfortable on their belly. But we tell them the reason we're doing it is that because they're hooked up to monitors. So we know if there's a breathing problem or something going on. Acupuncture, vibrotactile stimulation have all shown to help, although not widely used. And then skin to skin, of course, is one of the better things to do. This is that neonatal abstinence scoring system. I'll have you look that over in your own time. And then again, this is kind of an algorithm showing, hey, we started that Finnegan, we did that assessment and within 24 hours of birth, and now based on the score, these are what we might do. So again, giving that phenobarbital or that morphine drip, and etc. So again, I'll have you look at that at your own. Fetal alcohol syndrome, it can be a small amount of alcohol, it can be a large quantity of alcohol. It really depends on the different levels where that baby is in its growth and development in fetal state. Those babies tend to have low bridge nose, some ear abnormalities. They tend to be bigger and lower set. They have an indistinct kind of this lip, upper lip is kind of missing and flat. They have the upper lip is thinner, just not even there. A flat mid face, a short nose, and these weird epicanthial folds. So again, they have a very distinct look to them. especially as they grow up into children. So here's showing you this boy where he looks like as a child, but what he looks like in as an infant. You can see that's very flat there. It's hard to see here, but his ears are kind of lower set, missing that upper lip. And then these are some children as they got older, all with fetal alcohol syndrome. Fetal alcohol syndrome has a lot of effects on development and definitely on personality in the brain. So a lot of hyperactive behaviors, learning disabilities, a lot of IQ problems, depression, anxiety, OCD, poor judgment, speech delays, attention deficit disorder, and some memory issues. So some very terrible effects, actually. Hemolytic disorder, so this is where we talk about the blood incompatibility. So maybe you meet a mom who didn't have any prenatal care, she never got her RhoGAM, so that baby's blood could be being attacked and it could come out and have some problems, especially jaundice, but even in worse, more significant situations, a lot of other issues, organ failure, fluid, not enough fluids, etc. Prevention really is to give that RhoGAM, but if we know there's a problem, that baby was exposed, and we have some ultrasounds that's showing it's a problem, they even in some institutions do intrauterine transfusion, blood transfusion on that baby. So it's pretty awesome to see that. We can do fetal surgeries while baby's in mom's belly, and definitely an intrauterine transfusion. You can Google some of that stuff if you're interested. It is quite fascinating. This is again showing you, we went over this a few times in class, but if you're unclear, you have a mom whose first pregnancy where baby has a positive, but mom is negative. So there's some mixing of blood when the baby's born, and then mom's body makes these antibodies against the positive blood type, which is perfectly fine, except for those antibodies remain in the mom's belly. And then when she gets pregnant again, her blood attacks baby's blood, and that causes those issues. In diabetic moms, we talk about macrosomia, and that is an increased risk of birth injuries, especially from shoulder dystocia. And they actually have an increased risk of some congenital anomalies too. So having diabetes and not well controlled comes with some risks. Nursing care, again, is adequate thermal regulation, making sure those babies are eating appropriately, and checking those glucose levels. Congenital anomalies are really quite increasing in incidence in our country, and that probably has a lot to do with our drugs and our medicines and our lack of teaching people how to take care of themselves before they get pregnant, etc. The leading cause of death in infants less than a year is congenital anomalies. Most are detected at birth or shortly after. So you think you're having a normal baby and something comes out and it has a mild gastroparesis, or it's having trouble breathing, and we know there's an issue with the trachea, or all of a sudden it crashes and we diagnose a congenital heart defect. So definitely this is why close observation of that baby is so important those first few hours after life. Some of these things are treatable with surgical techniques. The baby will have to be transferred to a NICU. You might, while you're in Muskegon, see that happen. A lot of times because of prenatal care, we diagnose a lot of this stuff via ultrasound ahead of time. So these women are delivering in the hospital with a NICU team ready to go. But sometimes they don't know and they come in, and then we have to do a transfer. And it definitely takes an interdisciplinary team, multiple people, multiple disciplines helping to figure out if we can save that baby. There's multiple congenital anomalies. We're going to cover those in those individual chapters as we do PEDS. So this is kind of a layout of some common ones and where we're going to be covering them. So if you're doing one of these chapters as your partner assignment, definitely look to that. Preterm and postterm infants. So preterm, of course, comes with a whole slew of problems depending on how preterm, and of course that mainly has to do with breathing. But very preterm babies have a lot more complications as well. But respiratory distress syndrome is what we technically call those babies that struggle breathing, and that's a surfactant disorder. So you need surfactant to open up your little alveoli in your lungs to take in air to make them compliant, and when you don't have that, you can't do that. There are some other respiratory disorders, transient tachypnea of newborns. So sometimes newborns are breathing really heavy, and it's just they're having a trouble with the transition stage, and that usually resolves within a day, as opposed to RDS where it doesn't resolve and there's some other complications. Necrotizing enterocolitis also can happen. That's where part of the bowels die, and it's very dangerous, and a lot of babies can die from that if they get that. Okay, respiratory distress syndrome. Again, you're breathing more than 60 breaths a minute. Baby's breathing more than 60 breaths a minute. Dyspnea. They have retractions, intercostal and substernal retractions. So retractions and these audible grunty noises, which sometimes sound like cute little baby cues, and then nasal flaring tend to be your three big signs. Of course, if they're blue, that can be a problem, or they're not breathing at all. They have long periods where they're not taking breaths. And then we'll start to see some deteriorating vital signs. So this is showing a nurse administering some surfactant. So that goes right down an ET tube into the lungs. So we give surfactant if they're in a place that would have to be Grand Rapids or U of M in Michigan, or Wayne State, and maybe even now in Muskegon, I don't really know, but really important, definitely for the micropreemies. You can see this is a very, very young baby. It has that plastic wrap that's probably goes around it most of the time. This is just another example. This baby's being bagged and they're sending that surfactant down. This is a baby that was just born, and it is being resuscitated. There's a bag here, and you can see here it's kind of covered in this yellow, like its vernix is yellow, and that's because it had a poop before it was born, so it had meconium, stained amniotic fluid, which can be a sign if a woman has meconium fluid when she ruptures. Babies aren't supposed to poop before they're born, and if they do, it's because there was a stressful event that happened. So we don't always know what that event was, but it is a sign that we might run into some trouble. Preterm infants, again, they're born before 37 weeks. Most of their organs are not mature yet, their brain, their lungs, everything. So we don't really know what causes premature birth, but we do know that they tend to be small. They have, they're scrawny, they have large heads, small bodies. Their skin, depending on how preterm they are, can be translucent, red, sticky, see-through. They have a lot of that lanugo hair. Late preterm babies, so the ones that are born between 34 and 37 weeks, are at higher risk for problems with thermoregulation, hypoglycemia, hyperbilirubinemia, sepsis, and respiratory dysfunction. Post-term infants, the ones that go past their due date, it's not uncommon. So between 3 and 15% of pregnancies will go beyond that, and that's okay. Except for we talked about that placenta ages, so sometimes the placenta is not functioning, so labor can be kind of dangerous. We might have a crash delivery, and there might be the mortality of the baby increases as time increases. So again, risk of birth injuries: is that baby too big? Is there shoulder dystocia? Did we need a C-section, etc.? So the care of the high-risk newborn, again, respiratory support is where we start usually. This is showing a baby on a CPAP, which you'll probably see in Muskegon. So we definitely have to assist their ventilation. There is other kind of ventilation. The very premature infants might even be put on an oscillating ventilator, which is this fan that breathes really fast, like 100 to 200 breaths a minute. So there is different types of ventilation that occurs around here. You guys will see mainly CPAP. Thermal regulation is important, so do we need to put them in a thermal neutral environment, which is the incubator, where we control the temperature and the humidity? Do we need to put them skin to skin, etc.? Protection from infection is super important. Their immune systems are not adequate when they're preterm, especially. So we want to make sure we're using standard precautions, really good hand washing, and teaching patients and family to do that and not have their baby around a bunch of people. Again, I talked about this in class, but super important. Hydration, nutrition, making sure they're getting enough feedings. And when they're premature, we may have them breastfeed if they're late premature and see how they're able to maintain their oxygen sat. A lot of times we put them on IVs and then transition them to oral fluids as their maturity and their breathing gets better. And sometimes that means we give them a bottle and kind of test it out. Sometimes that means we do gavage feedings, and this is showing a neat baby getting a gavage feeding. Um, so we really want to conserve the baby's energy. So definitely those very premature babies, if we have to change an IV, change a diaper, do any kind of dressing changes, we're going to go in there as a team and do that all as quickly and all at the same time as we can, because when we touch those babies, they tend to desat and stop breathing or whatever. They decompensate. So really trying to conserve their energy, appropriate skincare, talk to families about developmental outcomes. Those premature babies are going to be behind the boat on all of that stuff. And then facilitating their relationships. So it's really hard to bond when you can't hold your baby because it's in an isolate. All my children were in isolates for anywhere from 3 to 7 days before I could feed them. And that is a really hard thing as a parent. So not forgetting the parents in that situation. And then planning for discharge and home care. Newborn screening is, again, we talked about that a little bit earlier, but they're looking for inborn errors of metabolism, such as congenital hypothyroidism, PKU, galactosemia. So those things we can get on this screening. So here it's showing you a heel poke, and we have to fill out all these little circles, and then we send that to the state, and they get those results. So if any of those come back, there will involve a genetic counseling and evaluation. We also test babies for hearing. Because if we know that bonding and development can be highly impacted if that baby cannot hear, and we want to catch that as soon as possible. So a lot of times babies will fail a hearing test, and it has to do with some of that Bernex and fluid still being in there. So we just have them come back a few days later after they go home to retest it. And we got to talk about fetal loss or fetal demise or death of a baby after a birth. Again, if we know that the baby is already dead, preparing the parents during that labor process, providing end-of-life care. I think it's all terrible. I've had to do many of these. But if you have a baby that's born premature and having those conversations with the parents, like, this is going to be a very premature baby. How much intervention do you want us to do? Some parents are like, nope, I'm just going to hold that baby and we're going to cuddle and love that baby as it is end of life. But some parents want every intervention you possibly can, put it on a ventilator, do all the things. So really having those conversations and preparing them. It's really important that we offer them the opportunity to hold their infant before death if we know it's going to die. So just immediately giving that baby to the parent. And even if they are delivering a dead baby, we keep the moms and babies together. We don't have to take that baby right away. You know, in some cultures like Australia, those moms stay for a week and they have that baby. It goes between the morgue and the mom for a week so that they have that time to get to know their child and to grieve before they say goodbye. So it might not be, I don't think I'll ever put you guys as a student with a fetal demise baby, but you might in that role be, helping a mom hold and love her baby and the family that had already passed. And of course, those babies are pale, there's white, and they can get stiff depending on how long they've been dead. Blue lips, they're going to look, unfortunately, like a dead human. But definitely what we do in labor and delivery world is we have a whole team that puts together handprints, photography, footprints, locks of hair if they have hair. Volunteers usually makes gowns and hats of all sizes, so we can get pictures with the baby in these beautiful gowns and hats and then send them home with those gowns and hats as like memorabilia. We do ID bracelets. A lot of times we'll make beaded bracelets with either the patient's name or the date or whatever they want on it. Kiss prints, where we put lipstick on the baby's lips and we press it on paper so they always have their baby's hugs and kiss. And if they'll have clergy come up and baptize the baby and have a certificate of baptism if that's part of their religious beliefs. So it is a lot of work as a nurse to put all this together, and I think it almost helps the nurse too, because we're just as sad and grieving with that family. So sometimes we do all this stuff even if the family doesn't want anything to do with their baby. They're like, please just, when it's born, take it away. I can't deal with that. Because a lot of times parents will come back later and be like, hey, do you have that stuff? I kind of want to look at it now. Oops. So here's a case study. We're going to go over that case study in class, but I'll let you read it here on your own. Basically, it's looking at a baby who was born with some club feet, And club feet, there's numerous interventions. I was born with club feet. We can put them in bars, we can do surgery, we can serial cast them. There's a lot of things that go on there. Definitely needs a referral to a pediatric orthopedist. When planning care for an infant with a fractured clavicle, so I had a shoulder dystocia and we had to fracture that clavicle to get him out, the nurse should recognize that in addition to gentle handling, which of the following should be implemented? Prone positioning, nothing additional. Parents will perform range of motion exercises or shoulder immobilization with a splint. And the answer is the shoulder immobilization. So if we have an infant that either we know we broke the clavicle on or is really sensitive there and we feel that clavicle and it feels broke, we'll get an x-ray, and if it is, they'll do this special splinting for the baby, just like we would a human, adult human or child. So that is all I have for this chapter. Thank you.